and welcome back. My topic for today is erysipelas. The definition says that erysipelas is an acute inflammation of the lymphatics of the skin and the mucous membrane. So basically, erysipelas is a type of superficial cellulitis with dermal lymphatic involvement. The only difference between cellulitis and erysipelas is cellulitis will affect the deeper tissues also, but erysipelas will affect only the upper layer of the skin. Causative organism is Streptococcus pyogenes, and precipitating factors involve malnourishment and chronic diseases. These are common in children and in old age. Next is pathogenesis. Here the organism will gain entry into the body through a minor wound or a scratch. Then the disease will spread from the site of inoculation, means the site where the organism has entered. From there it will start spreading and will result in advancing margin, which will become bright red and slightly raised above the genital surface. Here the margins are irregular, and now the lymphatics will get crowded with the streptococci, resulting in lymphangitis in the upper layer of the skin. Even the spaces that is in the corium of the skin is now crowded with the cells, that is mononuclear cells. The common site where erysipelas develop is face, eyelid, scrotum, and in infants the umbilicus. Then comes clinical features. In clinical features, we can see rose pink rashes with raised edges, which is better felt than inspected, means it can be easily palpated. Then later vesicles develop. Then there is serous discharge from these vesicles. When it affects the skin below which there is loose areolar tissue, example, orbit, scrotum, etc., there is considerable swelling of the part due to the edema of the subcutaneous tissue. So here this swelling is seen only when there is loose areolar tissue present just below the skin. Then features of toxemia are seen. I have already shared the difference between cellulitis and erysipelas. That is, cellulitis affects the deeper tissues also, but whereas erysipelas affects only the upper layer of the skin. Here are few more differences. That is, the typical rose rash will disappear on pressure and feel stiff. This is seen in erysipelas. The raised rashes of the erysipelas has sharply defined margins, which is better felt than inspected. I have already told this point in the clinical features of erysipelas, that is, later there is development of vesicles and there is serous discharge from it, but in cellulitis it contains pus. The next difference is erysipelas of face involves the pinna, because erysipelas is basically a cuticular lymphangitis. This is described as Million's ear sign positive. This sign is used to differentiate the cellulitis of face from that of the facial erysipelas, because in cellulitis the pinna does not get involved because of the close adherence of the skin to the cartilage. This complication, which involve toxemia, septicemia, gangrene of the skin and the subcutaneous tissue, can occur. Lymphedema of the face and the eyelids can occur because of lymphatic obstruction, which causes fibrosis of lymphatics. Treatment involves injection crystalline penicillin, that is 10 lakh units every 6th hourly, IM or IV for 5 to 10 days.
If you like my video, please don't forget to subscribe my channel. Thank you.